Hello my friends, welcome once again. My name is Dr. Said Kazmi. You're watching my YouTube channel, and today we will be talking about septic arthritis and osteomyelitis. These are two very important clinical entities related to pediatric orthopedics and musculoskeletal system. So without further ado, let's dive in and get started. Now, septic arthritis and osteomyelitis, they both are very closely related with one another. In many cases, you might find that these two entities, they are related to one another, or one leads to the other one. So let's start with the definition. Basically, septic arthritis means bacterial infection of the joint space. Joint space anatomically are those areas where two bones, they unite with one another and where there is movement. There may be movement or might not be movement depending on whether it's a mobile or a non-mobile joint. But if that space is invaded by a bacterial infection, that we call as septic arthritis. So septic arthritis basically means bacterial infection of the joint space. Another entity which is closely related with that is the infection of the bone, sparing the joint space. But usually it happens like close to the joint space, because an infection in the bone can go to the joint space and the joint space infection can go into the bone. So very closely related to one another. But osteomyelitis basically means infection of the bone, and in many cases this means like the long end of the bones. And by and large, any part of your human body skeletal system can be affected. It can get infected. But clinically we have seen that these are mostly the long bones, especially the lower limbs, that get infected. So you will find most of the time osteomyelitis occurs in the lower limbs, and the same goes for the septic arthritis. Like mostly it occurs in joints of the lower limb, but that doesn't mean that it cannot occur in any other joints. Like sparingly you might see that it occurs in other joints of the bodies as well. Now, clinically these entities are not that common. I mean, it's not something that you would see every now and then. But these are entities which you would never want to miss, because they can have serious consequences, sometimes even fatal consequences if these are missed. So moving further, what causes the infection in the joint and what causes infection in the bones? In other words, what are the common types of bacteria that can cause infection in the bone and the joint space? Now, it depends on the age and depends on certain circumstances as well. For children who are less than 5-6 years of age, one of the most common organisms that can cause osteomyelitis is Kingella species. So Kingella kingi is nowadays the most common cause of osteomyelitis, especially in children less than 6 years of age. In neonates, like those who are less than 1 month of age, if they get septic arthritis or osteomyelitis, most of the time these are caused by group B species. So group B streptococci, or rarely can be caused by E. coli as well. So group B, strep, and sometimes E. coli is mostly found in neonates. But remember, from exam point of view, the overall most common cause of osteomyelitis as well as septic arthritis still by and large is Staphylococcus aureus. So if you look the overall age spectrum, like whether you take pediatric age group or whether you take the adult age group, and if you combine them together, you will see that majority of the septic arthritis and osteomyelitis is still caused by Staphylococcus aureus. So it's overall the most common organism. In certain subtypes, like those kids, especially who are from Afro-Caribbean descent, and if they've got sickle cell disease, Salmonella species are also notorious for causing septic arthritis in these children. So where there is sickle cell disease, you should always be thinking of Salmonella species, which can cause septic arthritis. Those people who are playing sports and they get penetrating injuries, like tennis players or athletes or something, and if they get like penetrating injuries because of a nail or something, anything which is pointed, lying there on the dirt or on the road or on the tarmac, concrete, whatever, most of them, if they get penetrating injuries and that leads to osteomyelitis, the most common organism in those cases is Pseudomonas, because Pseudomonas basically thrives in the foam of the shoes, and if a nail goes through that, so it will pick up some of those bacteria, and it causes a penetrating injury. So this bacteria will be pushed inside, and then if it is close to the bone, it can simply traverse and go inside the bone and can cause osteomyelitis. So penetrating injuries, you should be thinking of Pseudomonas species, which can cause osteomyelitis. While last but not the least, especially in teenagers who are sexually active, a rare cause of septic arthritis in these subgroup are gonococci, which we call as gonococcal arthritis. So Neisseria gonorrhoeae, which basically causes gonorrhea, can also cause gonococcal arthritis or gonococcal septic arthritis in sexually active teenagers. So these are some of the common bacterial causes of osteomyelitis and septic arthritis in different subgroups and overall, which you should remember, because most of the times if you have to start empirical therapy, first of all, obviously in most of the cases we need to know the exact bacteria that is causing the infection, because then you can tailor the antibiotics based on the sensitivity pattern to find out the best antibiotic for that particular condition. But if you have to start empirically, you should know what are the common organisms in those particular subsets of the population, so you can start them on empirical till you get definitive results, and you can further tailor your antibiotic therapy toward the organism. Now, how do they present? Clinical presentation. Now, clinically presentation of septic arthritis is usually an insidious onset of single painful joint. So the history usually is that all of a sudden, out of nowhere, or sometime it might be coinciding with a minor trauma, though the trauma itself might not be the cause. But sometimes we have seen in practice that people give a history of a minor trauma. Nevertheless, what happens is that after the trauma, or there may be no trauma, one fine morning the child wakes up and he starts having pain in his joint. So usually it starts in the very beginning with a painful joint. Now at this point in time, the joint is not swollen. So most of the time, if they present to the emergency department or primary care, they mostly would be complaining of pain in the joint, and especially if that joint is in the lower limb. As I told you earlier, that lower limb is most commonly involved, and knee and hip are the most common joints involved in septic arthritis, especially in the pediatric age group. So they would be complaining of pain in their hip or pain in their knee. And after, obviously, if you're thinking of a swollen, hot, tender joint, that usually does not happen in the first few days. It would always start with a normal looking joint, but it would be painful. In the beginning, there is usually no fever. So you might think that it might be a transient synovitis, it might be minor trauma, or might be nothing, maybe overused, the child has been doing a lot of sports or things like that. So there are chances that it may be missed. So in the beginning, it's very non-specific. It's usually insidious onset of single painful joint. So this is very, very important. It would not be swollen if the child presents in the first 2-3 days. Yes, if it lingers on for some time, what would happen? This pain would be followed by swelling of the joint. Now swelling, remember, as I told you, it's never present in the very initial phase. So once it is swollen, then at that point in time, there might be other constitutional symptoms like a low-grade fever, etc., etc. So usually fever occurs a bit late. So by the time the joint is swollen, then the fever would kick in. But sometimes in immunocompromised children, like let's say who are on steroids or who have got some underlying condition in which they cannot mount an immune response, in that particular case you might see that there is no fever, because sometimes in practice we think that septic arthritis would be the way we are taught. We think of a hot, red, swollen joint in a febrile child. Well, I mean, in practice you can see it, but that would be mostly late in the presentation. In the beginning, just pain, and then later on a swollen joint, fever might be there, or as I told you, in immunocompromised kids, there may be no fever at all. So you have to take the overall context into consideration when you are thinking about septic arthritis. Now, usually as I told you that because mostly the lower limb joints are involved, the child might come up with limping, or if he's small one, inability to weight bear. So they might say that, okay, since this morning, especially if the child is a small one and he cannot give you the history, they say since morning he has woken up, he is refusing to bear weight on his legs, so he has to be held or he has to be carried. So this could also be the presentation, especially if the lower limb joints are involved. Now, as I told you that neonates can also develop septic arthritis and osteomyelitis. In that particular case, the organisms are mostly those which can be transmitted through the familial genital tract, like the group B strep or the E. coli. Neonates, usually they can't give you the history, so they usually present with increased irritability. They might develop swollen joints later on or might not develop it, but usually the history is that the child is very irritable, especially when the child is being touched on the affected limb. He starts crying, he starts very fussy, or he is not moving that part of the body. So especially when they are changing diaper, the child cries a lot, screams, or if he's handled, he cries a lot. So that is usually the history in neonates, where you should be thinking that there might be a possibility of a septic arthritis or osteomyelitis. There could be other common reasons as well. I mean, child might be fussy because he's got infantile colic, or might be suffering from other more common things. But remember, if it is very atypical, a particular limb not being used, or cries simply because if that part is touched, they say when they touch the skin he cries, then in that particular case you need to think whether there is an underlying osteomyelitis or underlying septic arthritis, or maybe even trauma. You never know. There could be certain types of bone diseases which can present with pathological fractures, and that might be the cause. So anyhow, a child, a neonate especially, who is very fussy, irritable, and cries, especially when he's handled, think about septic arthritis and osteomyelitis when you are thinking about your differentials as well. Now, because osteomyelitis is because it's a bone infection, and it doesn't behave like other infections. It's not like child is fine and all of a sudden, I mean, in the evening he develops a high grade fever shooting up to 39-40. It's never like this. It has got a very less conspicuous acute phase, so it goes very slowly. There is like a chronic onset of fever, slowly and gradually. So it usually starts with bone pain, and then over a period of time there is low grade fever. And in older children you might see that the history is a bit prolonged. It might be like a couple of weeks of history, the pains going on and off, and then the child having fever, and maybe somebody then starts documenting the fever, and they find out, like, it's been a low grade fever that's been lingering on. But what would happen is that the pain would progressively get worsened, and there would be a limp, and there would be progressive disability, especially if the lower limb bones are involved. So this you should always keep in your mind. Now, for septic arthritis, we use the Caucus criteria because remember, the thing is that we need to actually diagnose septic arthritis by analyzing the joint fluid. Now, you won't blindly pass an arthroscope into every child who presents with knee or hip pain. It's an invasive procedure, so you have to see whether there is any probability of septic arthritis or not. So it's a game of probabilities, and for that we use the Caucus criteria. So Caucus criteria uses 4 things, and that gives you the probability whether there could be a possibility of septic arthritis or not. So there are 4 criteria, and for each of these 4 criteria you will give them 1 mark. So if a child is non-weight bearing on that particular affected side, so child is non-weight bearing on his left lower limb or right lower limb, you will give 1 mark for that. You also have to do certain types of investigations in order to see the probability on Caucus criteria. So you have to do blood tests, especially the ESR and white blood cell count. So if the ESR is greater than 40 millimeter per, like at the end of the first hour, you will give another 1 mark. If the white blood cell count is greater than 12,000, again you will give 1 more mark. And if there is documented fever, then you will give another 1 mark. So the total possible scores are 4. So if somebody who on the Caucus criteria scores just 1 out of 4, like he's just non-weight bearing, or he just has got fever, or just white blood cell count, but usually, as I told you, the most of the time they won't come that like they've got a high white blood cell count or something, because that is only the lab tells you. Usually it would be, they would be coming with non-weight bearing on the affected side. So this is the most common thing, presentation, when you're looking at the probability of septic arthritis in the Caucus criteria. So if 1 out of 4, let's say he's just non-weight bearing, you haven't done anything else, the probability of having septic arthritis is 3%. It's quite low. It's quite low, like 3 out of 100 cases of septic arthritis would just present with non-weight bearing on affected side, with the rest of the criteria being totally negative. If somebody has got 2 or 4, so he's got fever and non-weight bearing on that, and you haven't done blood so far, again the probability now increases to 40%. So that's why whosoever has got fever and inability to weight bear on that particular side, it's important that you check white blood cell count and ESR. So with 2 out of 4, the probability increases to 40%. So like 40 out of 100 would be having this. Then if there are 3, like let's say fever, non-weight bearing, or non-weight bearing with ESR, any these 3 of these 4, the probability increases to 93%. So like that is a very, very high probability. And if you got 4 out of 4, that's like almost diagnostic, 100%, almost 99% probability. So Caucus criteria is very important. I mean, people don't realize, because we don't see this entity very, very common in our practice. But if you are mixed up in your differentials, what it could be, just use the Caucus criteria, okay, and it will give you a very beautiful like probability of whether it could be septic arthritis or not. And from that point onward, like, you can think about your further differences and you can tailor your further workup. So Caucus criteria, remember, the maximum score is 4 out of 4, the minimum could be 1 out of 4, and that gives you the probabilities of septic arthritis. Caucus criteria is only for septic arthritis, not for osteomyelitis, just for septic arthritis. Please keep it in mind. 4 things: inability to weight bear, fever, high white blood cell count more than 12,000, and an ESR greater than 40 millimeter at the end of the first one. These 4 things must remember. Moving on, diagnostic. So obviously Caucus criteria is not diagnostic, it's just give you the probability. How would you further go with that? The best initial test always is X-ray. Whether you're suspecting osteomyelitis or septic arthritis, the best initial test is always X-ray of the concerned bone or concerned joint. Why? Because if there is, let's say, a subtle trauma, if there is a fracture, or if there is a bony pathology which is responsible for that, that would be picked up. Like a neonate who's been born with osteopetrosis, marble bone disease, or osteogenesis imperfecta, and that is causing pathological fractures, and the child is crying because he might have something. So if you do an X-ray, you would see that there are particular findings, bony lesion findings, which you can pick up on the X-ray. So best initial test is always X-ray. Why? Because the thing is that it doesn't like diagnose septic arthritis or osteomyelitis. It just helps you in ruling out trauma and certain types of bony pathology. So it rules out fracture, because obviously fracture is under one thing, or maybe it would be the result of non-accidental injury, something that helps you in ruling out that thing. Now usually in case of septic arthritis and osteomyelitis, it's normal in the initial few days, like I would say probably in the first 2 weeks, X-ray doesn't show anything. You can have clinically a child with a swollen knee, but if you do the X-ray, you might see soft tissue swelling and a bit of joint effusion, but other than that, it won't show you anything. Similarly, you do with osteomyelitis, won't show you anything. You will just see a normal bone. So for septic arthritis, the diagnostic test is arthrocentesis. So you have to put an arthroscope inside the joint, take the fluid out. So you have to take the joint fluid and you have to analyze it. You have to look it under the microscope. You have to do a gram staining on it. You have to do a microscopy on it. You might even have to do a culture on it. So you need joint, synovial joint fluid. How would you get the synovial? You aspirate it. So arthrocentesis, sometimes at the same time, if there is turbidity or something, you can do a joint washout as well. So you have to go inside the joint. Remember, the best diagnostic test for septic arthritis is synovial fluid examination, culture, and sensitivity of the synovial fluid. So that has to be aspirated, washed out, whatever. That's usually done by the orthopedic surgeons. So it's usually a pediatric plus orthopedic team joint action to deal with septic arthritis, and for that the diagnosis is based on synovial fluid examination. Examination means you do gram staining, you do microscopy, and you do culture and sensitivity. For osteomyelitis, how do we diagnose that? Usually, as I told you, X-rays are usually negative in the first 2 weeks, Later on, it might show some findings, but again, like it's not very sensitive, not very specific. Uh, Good modalities are MRI and nuclear scans. So MRI is very sensitive in picking up early changes in osteomyelitis. Sometimes if you are suspecting multifocal osteomyelitis, like there are certain conditions which are basically non-bacterial, chronic, recurrent osteomyelitis. In that particular case, technetium-99 nuclear scan, like then you can do the whole bone scan and it will show you the hot spots where there might be some activity, inflammatory activity going on, and then you can pick it up. So technetium-99 nuclear scan and MRI are the best modalities for diagnosing what? Osteomyelitis. But if somebody asks you what is the 100% accurate diagnostic, that is bone biopsy. So you have to take a bone biopsy, but obviously rarely done these days. The best is MRI these days. Like most of the centers have got MRI machines with them, so MRI or a nuclear sense, technetium nuclear scan. So these are the best diagnostic modalities for osteomyelitis. So again, if you start with best initial for both is X-rays for septic arthritis, joint fluid aspiration for gram staining, microscopy, culture, and sensitivity for osteomyelitis is MRI or nuclear scan, while the gold standard would be bone biopsy, obviously not done these days. Okay, so coming down to the many phases of osteomyelitis. So if you look at the first image over here, the one on the left side. So if you see, this is a long bone, this is a femur. So down at the lower end of the femur, you can see that there is a lot of new bone formation. If you look, like if you trace from above, you can see here is the cortex over here, normal, thickness of the cortex. But if you come down here, you would see that the cortex is quite thickened. So something is going on here. Why would you get cortical hyperactivity at the jaw? So it means there is some form of inflammation going on, and that inflammation and bone necrosis is being replaced by new bone formation. So you see like hyperactivity, cortical hyperactivity. That actually is suggestive of what? Osteomyelitis. Here in the second one, here you can see this is a child's tibia and fibula, lower leg, and here you can see a lot of subperiosteal bone formation. So can you see this is a lot of subperiosteal bone formation? And this periosteal bone formation usually occurs when the bone is getting destroyed. So there is a chronic low-grade destruction of the bone, which is followed by reconstruction through cortical activity, subperiosteal bone formation. So subperiosteal bone formation under the periosteum is the hallmark of osteomyelitis, which you might pick up on the x-rays in the later phase. Remember, you won't find these in the initial few days or few weeks. You would usually find it after a couple of weeks when the destruction has gone on to the extent when there is a new bone formation. Here you can also see that there is a lot of activity, subperiosteal bone formation with hypolucencies and hyperlucencies, which means that at the same time there is destruction and formation of new bone. Destruction of the old bone and formation of the new bone. And why would that occur? That is simply occurs because there is infection inside the bone, osteomyelitis. On the right one over here, if you see now, apparently looks normal except that there's some soft tissue swelling. But if you just focus on the lower lateral condyle of the femur, you can see that there is a bit of osteolytic lesion. So you can see that bone has been eaten up. There is a few cyst formation as well. So here the bone is being eaten up, the bone is being destroyed, and that is suggestive of osteomyelitis. Remember, none of these findings are diagnostic. This can occur in so many other conditions as well. You can see the sunburst appearance of new bone formation in osteosarcoma. There are certain other types of bone tumors in which you might get the similar thing. But again, if you connect the dots and if the history is suggestive, you can make the diagnosis of probable diagnosis of osteomyelitis based on these findings. But they are nonetheless, they are non-sensitive and not specific. But anyhow, if you are lucky in the like in the later stages, you can pick up these changes. So in case if you see these changes, you should be able to pick those changes, you should be able to diagnose that. So these are some of the few of the many phases of osteomyelitis. So osteomyelitis can present in a wide variety of ways. It can present with subperiosteal bone formation, subperiosteal thickening, subperiosteal what you call latic lesions, cyst, things like that can present in many ways. Okay, moving on to the differential diagnosis of osteomyelitis, or more so septic arthritis, because septic arthritis was usually present as an acutely swollen or acutely painful joint. Either it would be acutely painful or maybe acutely painful plus swollen, or a swollen joint. We call it monoarthritis because it's usually most of the time single joint involvement. So what are the other diseases or the other issues that can cause monoarthritis apart from septic arthritis? So as I told you, one is infection. Septic arthritis is the bacterial infection of the joint space caused by like different types of organisms: Staph aureus, Shigella, Salmonella, Pseudomonas, so on and so forth. It might be caused by what we call as crystal arthropathies. So crystal arthropathies are those conditions in which there is crystal formation inside the synovial fluid, and these crystals, then what they do is they rub against the synovial membrane. They cause damage, they cause inflammation that leads to further buildup of the fluid inside. So when there is inflammation and there's build, so that the knee is, or any joint where this would occur, would be hot and would be swollen. So we call them crystal arthropathies. So crystal arthropathies can usually occur in gout. So gout is a condition in which the uric acid is raised because of certain types of metabolic issues, problems with uric acid formation. So uric acid is raised, so that can cause gouty arthritis, or it could be pseudo gout as well. Usually these are the again crystalline arthropathies, but usually they are if they are looked under the bipolar light, so they would not show the crystal under that. But anyhow, there are crystalline structures which are formed. So it could be gout or pseudo gout or non-gout crystalline arthropathies. It could also occur as a part of generalized inflammation or inflammatory disorders. So it can happen in early stages of rheumatoid, like juvenile idiopathic arthritis or juvenile rheumatoid arthritis. It can also occur in what we call as seronegative spondyloarthropathies, which are more common in the pediatric age group. So like psoriatic arthritis, what you call there is condition ankylosing spondylitis, etc. Though later on it would have got a predilection to affect the spine or something, but nevertheless, sometimes it can cause monoarthritis. To begin with, it can cause monoarthritis. Some of the types of inflammatory conditions apart from rheumatoid arthritis are like sarcoidosis, SLE. They can cause monoarthritis. Similarly, those who have got blood dyscrasias like coagulopathies, especially hemophilia, they can have deep joint space bleeding, and because of minor trauma, if there is a bleed inside a joint, that would lead to a hot, swollen, painful joint. So remember, those are hemophilics, or those who have got blood dyscrasia or coagulopathies, and them bleeding inside the joint can also present as monoarthritis. While last but not the least, certain types of tumor infiltration, and especially in pediatric age group, if somebody is having bone pain or is having joint swelling and they look unwell, apart from septic arthritis and these things, and especially if they are pale, don't forget that leukemic infiltrations, leukemias and lymphomas can present with bone pain. They can present with joint involvement. So a child with sudden onset of limp, painful limp, not responding to painkillers, pallor, or has got bruising spots here and there, think of leukemias and lymphomas. Or certain types of bone tumors themselves, though rare, can also cause monoarthritis. So remember, it's not only the septic arthritis which is responsible for single swollen joint. It could be trauma, it could be gonococcal arthritis, which is again part of the septic arthritis, but then there could be crystalline arthropathies like gout. It could be part of the inflammatory disorders like SLE, rheumatoid arthritis, or it could be part of the coagulopathies, acute bleed inside the joint space, or last but not the least, most important, tumors, lymphoma, leukemias. They can also present with monoarthritis. Moving on to the treatment. Now treatment, and here we are talking about treatment of septic arthritis and osteomyelitis. So once it is diagnosed, let's say the synovial membrane, the synovial fluid examination, it shows that there are increased white blood cells, or the culture shows that a particular bacteria has been grown. So what you would do, then you have to treat that. So the treatment depends on the cause and the bacteria identified. So usually for osteomyelitis, we start with flucloxacillin. So if you are suspecting Staph aureus, which is the overall most common cause of osteomyelitis, you should start with empirical flucloxacillin. So we always start with IV antibiotics because penetration in the bone is quite poor. So you have to start with high dose IV antibiotics, and you look at the response. So once they have given a good response, the fever settles down, then there is the swelling starts getting resolved, then you would switch over to oral medication. So you always start with IV medications and then you switch over to oral medication. And usually the treatment is prolonged one. It's not like a 6 or 7 days course of antibiotics. You usually have to use it for a couple of weeks, so 3 to 4 weeks, sometimes 6 to 8 weeks, depending if they are complication that you may even go up to 6 to 8 weeks, but usually 3 to 4 weeks of antibiotic use, some of which is IV followed by oral antibiotics. So overall, empirical therapy for staph is to start with flucloxacillin. If the patient is penicillin allergic, then the best medication is clindamycin, and especially if you are suspecting, or the examination, the culture, the synovial fluid examination in the lab, it picks up methicillin resistant Staph aureus like MRSA, then in that particular case you have to go with vancomycin or teicoplanin. So this is how we treat flucloxacillin for staph. But if it is MRSA, then you would go with vancomycin or teicoplanin. For patients who are penicillin allergic, then you have to go with clindamycin. For septic arthritis, it's the same thing. Only exception is if you suspect gonococci, then you have to go with ceftriaxone, because ceftriaxone is very, very effective against gonococci. For Pseudomonas osteomyelitis, we usually give them fluoroquinolones, because fluoroquinolones has also got very good penetration in the bone, and that has to be given if you have to do, though there are other anti-pseudomonal drugs as well, but usually by and large fluoroquinolones are used for this particular purpose. And at the same time, if there is extensive bone destruction, there might be input from orthopedic surgeons, because it might need some form of bone debridement or osteotomy or bone reconstruction. So there might be some surgical input into the treatment as well. It depends from case to case, but if needed, then it would need bone debridement, osteotomy, or bone reconstruction. So this is how we treat the osteomyelitis and septic arthritis. So in this short lecture, I've just covered the main bacterial etiologies of septic arthritis and osteomyelitis. We talked about the presentation, which could be very treacherous, especially in the early days of osteomyelitis and septic arthritis. We talked about the diagnostics, and we talked about the differential diagnosis and the general principles of management of osteomyelitis and septic arthritis. If you still have got any questions related to these two entities, please put it down in the comment section below, and I will try my level best to answer your queries as soon as possible. And before I go, for those of you who haven't subscribed to my channel and are watching this video, please do subscribe and give me your feedbacks, and don't forget to smash that bell icon, so whenever I upload a new video, you are always on board with me. So have a very good weekend. Take care of yourself. Have a good day. Bye bye.